I'm Ron Donaldson. I'm an orthopedic surgeon, but have specialized in non-operative care for many years and research into particularly the diagnosis and classification of low back pain.
My name is Ryan Tazel. I'm a physical therapist, currently in private practice in Virginia. I worked many years in an interdisciplinary spine center.
I'm Todd Wetzel. I'm an orthopedic spine surgeon from Cooperstown, New York, and past president of NASS. I've had a long-standing interest in non-operative as well as operative care, and have been collaborating with Dr. Donaldson on these issues for a number of years.
One of the things we want to talk about today is how commonly we use patterns of pain to help us diagnose and make decisions regarding treatment as well. And it's interesting that how commonly we do use pain patterns. We talk about just the pattern of pain going down the leg, meaning sciatica, and that implies a disc diagnosis. Neurogenic claudication, worse with walking, better with flexion. That's a pattern that immediately connotes stenosis. We know and recognize that in a patient with back pain and leg pain, where the leg pain suddenly worsens, intensifies, and the back pain immediately goes away, we know that that annulus has just broken and the disc is now decompressed. And we use those patterns all the time for both diagnostic purposes, and then of course, once the diagnosis, that helps us determine the type of treatment we want to pursue. But there's also two other patterns that are not commonly used. They're fairly well known, but they're not commonly used across the spine space. And those are the patterns of directional preference and pain centralization. And I know you guys both are very familiar with those and use them clinically. How useful are those pain patterns in terms of decision making and diagnosis? And I'm interested in your thoughts.
Well, in a word, I think they're invaluable. This is actually a validated system. It's very common. In some studies, up to 80% of people have a directional preference when you look at a population. The assessment process to determine that is diagnostic and also therapeutic, because you know how to treat that. If centralization is present, it has a predictable outcome with non-operative care. Additionally, I think this tool is very, very valuable in the assessment of all patients, particularly patients with a so-called surgical diagnosis, as you mentioned, Ron, because many of those patients, despite having what looks to be a perfect indication for surgery, are able to be centralized and then treated non-operatively.
Mm-hmm. I use this pain pattern recognition every day with every patient, and it's not only it's not used just for treatment, but also to determine, is this patient somebody that belongs in my office? It's diagnostic. I can say if they don't have rapidly centralizing pain, then what do they have? And maybe they don't need to be with me, and then I can get them off to the surgeon as rapidly as possible. But it's the diagnostic method that produces the non-response that sends up some red flags for me, where I can say, you know what, you don't need to be with me. Instead of taking 24 sessions in order to determine that and saying, well, I guess physical therapy failed, I can do that within 2 or 3 sessions. So I think it has value in helping the patient get better, but also in determining what care pathway the patient needs to take.
And I don't think I mentioned the pattern of straight leg raising, which is a pain provocation sign, and those patterns that I mentioned at the outset are indicative of disc problems, the claudication, worse with walking, better with flexion, is stenosis. Those are relatively small percentage of the total population. Okay. Whereas the pain patterns of directional preference and centralization is 70–80% of the population. Yeah. And so they're so much more useful, but yet they seem to be less recognized and less used in spine specialist practice. Would you agree with that?
Yeah, and I'm not sure why, because it is such a useful tool. I'm surprised it's not more ubiquitous. Mm-hmm. It certainly is a very, very precise way of looking at a problem of low back pain. As you said, Ron, about 4% of patients with degenerative problems who present to an orthopedic surgeon's office actually have radicular pain. Most of it's axial pain. We tend to assign it to anatomic causes with no real good reason or no real good foundation. And the mechanical behavior is just so valuable in knowing where to take that patient.
Exactly. Yeah. Any other thoughts?
The idea of using the patient's response to movement is something that it empowers the patient. It takes the mystery out of the patient's pain experience, right? Because they come into your office, and to them, their pain is mysterious and random, and they have no clue why it's really occurring. Whereas when you lay a very logical, standardized process down in front of the patient, and they can see either the location of the pain change, or possibly one of their baseline tests, something like bending forward or going from sitting to standing. If they can see those things change in one session, now all of a sudden it's not mysterious, it's not random. It returns the locus of control back to the patient.
Exactly.
So now they are the ones in control. They are the ones that went from fearful to in control. And when they're in control, now they can be proactive. Because in my experience, most patients really want to do something. They just don't want to make themselves worse. They just want to know what to do.
Sure.
And how to identify that. And that's what this does.
And we're told in the guidelines, instructed that we should reassure patients that they're likely to recover and so forth. There's nothing more reassuring to a patient than to have their pain centralized and abolished with a simple movement that they can do with a therapist in the clinic. And totally, as you said, they realize that they have control of this now, and that's a revelation to them.
Yeah.
Because coming into that experience, whether they're depressed or they're lost in terms of any control, and they're just looking for some help. But when you can take their pain away, or you can show them how they can take their own pain away, that is incredibly reassuring that they're going to do just fine, and they now have a pathway to recovery.
Yeah, and I think Ryan made another very good point, and that's that this is not a process that drags on and on over months or weeks. The average number of visits is 4 to 6, usually, to get somebody centralized and self-treating, and that's astounding from the point of view of value, cost, and days off of work.
Absolutely.
I mean, that's a benefit that isn't realized about this that I think more people should be aware of.
Yeah, it satisfies the triple aim: better cost, better service, better experience for the patient, better outcomes.
And high patient and clinician satisfaction.
Absolutely.
Yeah.